Good morning. Today I have come with a topic on early pregnancy loss, which is a very important topic in clinical practice. I have come in this video tips for undergraduates, postgraduates, and also for clinicians to refresh their knowledge as these cases of early pregnancy loss are very common in clinical practice. Now coming to the causes for bleeding in first trimester or initial few weeks of pregnancy are abnormal gestation, and these abnormal gestation could be intrauterine, that is the developing embryo is implanted inside the uterus, or it could be extrauterine, which is also called ectopic pregnancy, and this will be dealt in a separate video. So in this video I will be talking about intrauterine abnormal gestations. And one more thing that I must stress here at this point is that early detection avoids complication in early pregnancy bleedings or early pregnancy loss, and this is very much important. So every clinician must keep this in mind, either you are an obstetrician or you practice any field of medicine, because any woman can come to you and this topic will be helpful for everyone. Now coming to the abnormal intrauterine pregnancy, as ectopic pregnancy will be dealt with separately, especially undergraduates must remember there are some 20s in this, like the spontaneous pregnancy loss is about 20% of recognized pregnancies. Those pregnancies that are recognized, almost 20% they result in spontaneous pregnancy loss. So this 20 again comes here. Any bleeding from the uterus coming before 20 weeks of gestation would amount to early pregnancy loss or abortion. It leads after 20 weeks, it is called differently, and it is called antepartum hemorrhage, but before 20 weeks is called abortion. Now about 80% of spontaneous pregnancy losses occur in first trimester. Again here it is coming 80-20. 20% of recognized pregnancies they result in spontaneous pregnancy loss, and out of these 20%, 80% are occurring in the first trimester and 20% are occurring in the second trimester. So first trimester pregnancy losses or bleeding is more common form of spontaneous pregnancy loss. One prior spontaneous abortion. If a woman comes with a history of one prior spontaneous abortion, the rate of subsequent spontaneous abortion increases by around 13 to 20%. So again, this figure of 20% is coming to you. Now 3 consecutive losses increases the risk of spontaneous pregnancy loss by 33 to 43%. Almost it reaches up to this 40%. So this is very important. 3 consecutive losses is also known as recurrent pregnancy loss, and it's this recurrent pregnancy loss, its investigation and management will be dealt separately in another video. Now one more thing, if a woman comes to you with an ultrasound which shows fetal cardiac activity is present, then the rate of spontaneous abortion is less than 1%. So if you can document fetal cardiac activity in an ultrasound of a woman, you can assure her that pregnancy loss chances will be very much minimal, and you are yourself rest assured. Now coming to the risk factors. What are the risk factors for spontaneous pregnancy loss? There are certain risk factors that are known, and increasing maternal age is a dose dependent risk factor. Higher the age of the mother, more are the chances of spontaneous pregnancy loss. So much so that fetal cardiac activity, when it is documented on USG in a woman who is less than 36 years, the rate of spontaneous abortion is less than 5%. After this fetal cardiac activity is documented, that 1% was for younger women. Now if a woman is less than 36 years and fetal cardiac activity is documented, spontaneous pregnancy loss is less than 5%. Between 36 to 40 year of mother, even if the fetal cardiac activity is documented on ultrasound, still it is 10%, and a woman who is more than 40 years, even after documenting the fetal cardiac activity, it is 30%. So in women who are older, you cannot assure just by seeing that fetal cardiac activity is present. You must impress the factor that maternal age is a dose dependent factor. Higher the woman's age, higher are the chances of spontaneous abortion. Now, another risk factors are if she has a previous spontaneous pregnancy loss. Previous one spontaneous pregnancy, we have seen that it increases from 30 to 20%, and previous 3 spontaneous pregnancy losses keeps it up to more than 40%. So, previous spontaneous pregnancy loss is also a risk factor for spontaneous pregnancy loss in this pregnancy. Now, if the pregnancies are closely spaced, if the duration between the last pregnancy outcome and this pregnancy is less than 3 to 6 months, the chances of this pregnancy resulting in a spontaneous pregnancy loss is higher. Now, if a woman is suffering from any systemic disease like diabetes mellitus or thrombophilias or any infection, especially infection, this is also important in second trimester pregnancy loss. Only bacterial vaginosis, if a woman has bacterial vaginosis, then the infection chances of second trimester pregnancy loss increases. So you must identify and treat this bacterial vaginosis cases early. Now, if maternal smoking is present, alcohol consumption, if it is moderate to high, and any maternal trauma that is severe enough to cause this spontaneous pregnancy loss. Now, these two are important when a woman comes to you in her for her preconception counseling. Then you must address these two features and impress the value that they must be quitting this, otherwise it will impact the pregnancy outcome. Now, risk factors, another is like increasing gravidity. It is indirect, it is not directly associated, it is indirect, because as the gravidity increases, if she becomes third gravida, fourth gravida, fifth gravida, that means her age is also increasing, and we have just seen that how age is important and dose dependent risk factor for spontaneous pregnancy loss. Then any uterine anomalies like septate uterus or biconjugate uterus, like in septate uterus, if placenta implants on the septum, then it may result in early pregnancy loss. Chromosomal abnormalities in developing embryo, this is very much important because it is a sort of natural check that conceptus with abnormal chromosomes are not allowed to take birth in this world. And embryonic gestation we will see in coming videos, coming slides. Then placental anomalies, extremes of maternal weight, and intrauterine device, if it is in place along with the pregnancy, then it has increased risk of causing spontaneous pregnancy loss. Now, in India, Global Network's Maternal Newborn Health Registry, which is MNHR, estimated that among ongoing 6 weeks pregnancy, if we take 1000 women who are at their 6 weeks of pregnancy, almost 40% will be lost before 20 weeks. This is a very important figure, that out of 1000, if we take 1000 women who are at their 6 weeks of pregnancy, almost 40% of such pregnancies will be lost before 20 weeks, and out of these 40%, 2/3 will be for spontaneous pregnancy loss and 1/3 will be for induced MTPs, medical termination of pregnancy, which is legal in India. This medical termination of pregnancy is legal in India. Now, coming to spontaneous pregnancy losses. These could be of following 4 types. It could be missed abortion, we will see in the coming slides. Threatened abortion, inevitable abortion, incomplete abortion. The name themselves says threatened abortion, the abortion that has not yet occurred but the bleeding has occurred. Inevitable abortion, that means abortion that has not yet occurred but it is inevitable and nothing could stop this. And incomplete abortion, the abortion that has started but the products of conception, some products of conception are still retained. So the name themselves are very much self-explanatory and we'll see them in detail now. Now coming to missed abortion. Missed abortion, that means you have missed. You could see them only on USG, ultrasound. Now, these are non-viable intrauterine pregnancies, right? We are coming to abortion, so it is non-viable and intrauterine pregnancies. Very much important. The cervix is closed, that means the abortion process has not yet started. There is minimal bleeding or abnormal uterine lower abdominal cramping. A woman comes to you with maybe minimal bleeding PV or with lower abdominal pain and you advise for ultrasound and you get to know that still the cervix is closed but the pregnancy or developing embryo is non-viable and ultrasound is the key to diagnosis, which is transvaginal ultrasound. You can detect earlier in case of transvaginal ultrasound. Now, there are two subtypes of this missed abortion. One is anembryonic gestation, which was earlier also called as blighted ovum, and embryonic demise. Now, what is anembryonic gestation? Where both the gestational sac is present. In anembryonic gestation, gestational sac is present, but fetal pole is absent. You have a gestational sac, developing gestational sac, but inside there is no fetal pole. How to diagnose that? At what gestational sac dimension fetal pole must be present, or you must announce it as this an embryonic gestation or missed abortion? We'll see in coming slides. And in embryonic demise, the name itself says that gestational sac is present, fetal pole is present, but cardiac activity is absent. So, at what dimension of gestational sac or length of fetal pole you will be able to see this cardiac activity, and if you are not seeing at what dimensions, then you will announce it as embryonic demise. This we are going to see in coming slides in detail. Now coming to anembryonic gestation, TVS or transvaginal scan when mean gestational sac diameter is more than 25 mm. I was just telling you about this. At what dimension of gestational sac without embryonic pole you will announce it as an embryonic gestation or missed abortion. It is 25 millimeters on transvaginal scan. This is very much important. It may also come in some form of MCQ for postgraduate examination also. So mean gestational sac diameter, if it is more than 25 millimeter and embryonic pole is absent or missing, then you may very well label it as missed abortion or anembryonic gestation, which was earlier also called as blighted ovum, but now we must avoid using this term. But I am mentioning it for clinicians who have already learned this in their undergraduate and postgraduates. Now coming to embryonic demise, at what gestational, when crown rump length is 7 millimeter and without a cardiac activity, and this is also on transvaginal scan. These dimensions they increase when you are using per abdominal scan, but we are using the values of transvaginal scan because the visualization is better from nearer the probe placed to the uterus. So when the crown rump length is more than 7 millimeter but cardiac activity is absent, you can label it as missed abortion. Now coming to threatened abortion. Threatened abortion, I just told the process of abortion has started. It has started, but it is threatened. It may or may not complete. Only the coming time will tell. Now coming to details, any vaginal bleeding occurring before 20 weeks of gestation, unless proved otherwise, is called threatened abortion. A woman comes to you in her early pregnancy with history of, with complaint of bleeding PV, either mild, dark, bright, or anything, and she comes to you, you will label her as threatened abortion. Now it occurs, we have already seen, it occurs in 20% of all pregnancies. So threatened abortion coming to you, the chances are very high, because 20% of pregnancies, they result in threatened abortion. Now USG documents viable intrauterine pregnancy. A woman in her early pregnancy coming to you with the bleeding PV, definitely you are going to advise her ultrasound, and on ultrasound report there is a viable pregnancy. Viable pregnancy means if it is more than 7 millimeter of crown rump length and cardiac activity is present, that means it is a viable pregnancy. Bleeding is light and it is associated, may or may not be associated with pain. And you must understand that 20% of all pregnancies, they result in threatened abortion, and out of this 20%, only 12% are going to result in pregnancy loss. So what is more important here is that more than that, almost 88% of threatened abortion will result in a good fetal outcome. That means viable baby may be born. This is more important. So you have to reassure the woman that although you have a threatened abortion, you have a viable intrauterine pregnancy, and only 12% are going to have this pregnancy loss, and there are more chances that pregnancy will be successful. Now coming to the what are the poor outcomes in later pregnancy. If a woman who has a threatened abortion in first trimester, and if she is able to reach her term, what poor outcome are associated with such pregnancies? There are 3 times increased risk of preterm births between 28 to 31 weeks of gestation. This you must understand, and you must keep an eye on such women, and you must give the steroid prophylaxis timely. 50% of higher likelihood of preterm between 32 and 36 weeks. So you can understand that they may not, 50% of such pregnancies, they are not going to reach the term, that is 37 weeks. And this is very much important, but 32 to 36 weeks outcome of baby is better. And IUGR is frequently seen in such pregnancies if they continue, because early pregnancy loss could have caused the demise of the chorionic villi, and definitely the blood supply to the fetuses has reduced. Now preterm pre-rupture membrane preterm premature rupture of membranes is more commonly seen in such pregnancies, and placental abruption is also seen. So it becomes a high risk pregnancy, and you are going to call this woman repeatedly and keep an eye on these complications that may develop in such pregnancies. Now, what are the differential diagnoses? Definitely threatened, although we are labeling every woman who comes with the bleeding PV in her first trimester, before her 20 weeks of gestation, 20 weeks gestation, coming with bleeding PV, we have seen that we have mentioned as threatened abortion. So there could be differential diagnosis also. Cervical, you have to identify them timely, so that you can identify that these women are not going to develop such complications that I have mentioned in their later pregnancies. Now on per speculum examination, you can see cervical polyp. So per speculum examination of a woman coming with bleeding PV in her before her 20 weeks gestation is must. Then vaginitis, cervical carcinoma, you can order a pap smear when bleeding stops. Then gestational trophoblastic disease, in such you very well know that what is the differential diagnosis. The period of gestation per abdominal, that means the uterine size is usually more than the period of gestation. The uterus is more doughy feel, and USG is the key to diagnosis. The ectopic pregnancy may also come with early first trimester's bleeding PV, and in the video of a ectopic pregnancy we will be discussing it in detail. Any trauma, so there is a history of trauma. It could be, such trauma could be act of coitus also. So you have to ask this in detail. And any foreign body insertion could also result into early pregnancy, bleeding in early pregnancy. So these are the differential diagnoses you are not going to miss. Now coming to physical examination, what is the abdomen is non-tender, cervix is closed, as I have already told you. Bleeding may or may not be seen when you are looking for per speculum examination, and there is no cervical motion tenderness or adnexal tenderness, and ultrasound is suggestive of viable intrauterine gestation. That means cardiac activity is present. Now coming to the management, what I would like here to stress for even clinicians also, that till date there is no effective therapy for threatened abortion. We write so many things, we write injections, we write multiple progesterones, but to date there is no effective therapy, and we have already seen that almost 88% of pregnancy they continue beyond 20 weeks gestation in such women. So even if you are not going to treat, almost 88% women, they will be carried to their later part of pregnancy naturally, and there is no effective therapy till date. Now what we clinicians usually advise is bed rest, and usually progesterone supplements in the form of injection, in the form of vaginal application, orally, and various formulations together, and sometimes you see all of them in the prescription. And legally speaking, this may cause more side effects rather than supporting the pregnancy. So when you advise excessive bed rest, we all know that pregnancy is a hypercoagulable state. It is a hypercoagulable state, and DVT may be precipitated if we advise prolonged bed rest to a woman of threatened abortion. And if we are giving very much progesterone supplements in various forms to a single woman, the side effects of progesterone will also be exhibited in such women. And legally speaking, there is no effective therapy. You just have to reassure and follow up the woman with minimal amount of medicines usually in the form of, what you have to do is supplements like folic acid, or if she is having vomiting, then you have to support that, or calcium supplements you can give. So there is no effective therapy till date in evidence-based medicine for threatened abortion. Now coming to inevitable abortion, the abortion has started, not complete, but nothing can stop it. It is going to happen. Cervical os is open and effaced, it is taken up, and now the process is not going to reverse back. It occurs before 20 weeks of gestation. After 20 weeks, we call it either preterm, or if bleeding is present, an antepartum hemorrhage. Now, POCs, products of conception, not passed out yet. Although there is a pain, there may be bleeding, but still the product of conception are inside only. Lower abdominal pain is crampy, bleeding is present, pain is excessive, then you can help in medical or surgical treatment. More important thing, you encounter Rh negative mother with inevitable abortion, NTD of 50 microgram is to be given before 12 weeks. If suppose you do not have a 50 microgram dose available with you, what can you do is you can also supplement, you can also give the usual 300 mcg dose, microgram dose, to women before 12 weeks. After 12 weeks, you have to give the full dose, but before 12 weeks, it is 50 microgram Suppose at a center you do not have 50 microgram dose, you can go ahead with 300 microgram. It will not going to be harmful to the mother, and you do not have to miss this NTD to a woman even with inevitable abortion or complete abortion or incomplete abortion. You have to remember this very well. Otherwise, we all know if we fail to give this, what consequences the woman will have to face in her future pregnancies. Now, coming to incomplete abortion, it is partial expulsion of products of conception before 20 weeks of gestation. You see partial, it is incomplete. Pain is present, bleeding is present, cervical os is dilated, POCs may be seen coming out, bleeding is present, and if it is bleeding is very much a cause of concern, or then what you have to do is surgically you have to remove the products of conception. It depends on the condition of the patient, cross match, IV fluids, antibiotics if a woman is febrile. So it is how much time she is into incomplete abortion. This is also in India, we see that woman usually comes even after 24 hours, and till that time they get infected, and if she is febrile then antibiotic is also to be given. If she has bled too much, then blood is also to, and she's in shock, then blood or IV fluids to stabilize the woman. All those things are to be kept in mind. And what I recently said, NTD as per patient's blood group, if it is less than 12 weeks, it is 50 microgram. More than 12 weeks, it is a full complete dose of 300 microgram. And if you do not have this 50 microgram of dose available with you, you can easily go ahead with 300 microgram also. Now coming to management of spontaneous abortion, we have seen, if first of all you have to understand whether the pregnancy is desirable or not. We have already seen that for out of 40% women who abort before 20 weeks gestation, 2/3 are spontaneous and 1/3 are induced. Sometimes woman induces herself by somehow any means. So first of all you must ask whether the pregnancy is desirable or not. Like if she comes with the bleeding PV and you label it as threatened abortion, if you get to know that woman is not desirous of pregnancy, you will be going to help this into complete abortion. You are not going to go on expectant management and reassure her. So you first of all, what are whether the pregnancy is desirable and what are her goals about pregnancy, whether she is desirous of childbirth in this pregnancy or not. Now it also depends, the management also depends upon the vitals. Expectant management success rate is up to 76%, but the time required is up to 4 to 8 weeks. You do not have to do anything. Most important there is expectant management. Just let the nature takes its course, and time required is very much high, and but the success is almost up to 76%. What are the drawbacks of this expectant management? There are increased unscheduled surgical evacuations. Sometimes woman happens to bleed at midnight and then she rushes to the hospital. So unscheduled surgical evacuations, the chances increases, but infection rate chances are not increased. This is important to understand. If woman lives near to the hospital or healthcare facility, then she can be allowed to go for expectant management. But if she lives in a far off place, it is better to avoid such management, because unscheduled surgical evacuation rate is increased and she may or may not reach your center in time for help. Now next is medical management with the misoprostol. The ACOG, when missed abortion is present, ACOG guidelines says 800 microgram of misoprostol vaginally for missed abortion. For incomplete abortion, the dose is less because the some process has already started. 600 microgram is enough orally, or 400 microgram sublingually. These are the American guidelines. And Now, one more thing, if we pre-treat with 200 milligram mifepristone 24 hours prior, it increases the efficacy of this misoprostol. So you can go with the first dose of mifepristone. As it is already the process has started, you do not have to need to wait for 48 hours. To only 24 hours prior priming with mifepristone 200 milligram is enough. It increases the efficacy of this medical management, and it helps reduce the surgical instrumentation in the woman. And now last one is the suction curettage. It is depends on the patient's choice. If she lives in a far off place, she cannot visit you frequently. With the medical management or with the expected management, the patient chooses the suction curettage at the first place only. And if the vitals are unstable, if she is into shock, she is bleeding heavily, then you do not have to wait for expectant or medical management. They are a big no, contraindication for these, and suction curettage is the only modality of treatment for such unstable vitals women. And another is, if you are of concern that patient may not come with the reliable follow-up protocol. Now, I talked to you in the initial slides that I will be talking about the guidelines on ultrasound in detail for non-viable pregnancy. So there are some diagnostic criteria and there are some findings that are suggestive but not diagnostic. So one by one I will be telling you. So diagnostic criteria: when the crown rump length is more than 7 millimeter and cardiac activity is absent. So this is a diagnostic criteria. Okay, now coming to mean sac diameter, if it is more than 25 millimeter and no fetal pole is there, this is also a diagnostic criteria. This diagnostic criteria is for anembryonic pregnancy, and this diagnostic criteria is for embryonic demise. Both come under missed abortion. So you will get ultrasound report of missed abortion. In such cases, earlier you used to get blighted ovum, but nowadays you get missed abortion only for both of them. You are aware that this is the an embryonic gestation and this is embryonic demise. Now coming to absence of embryo with heartbeat 2 weeks or more after, suppose a woman comes with you with a gestational sac, say 20 millimeter, and no yolk sac is present, and there is no embryo seen in this, so you are doubtful, right? What will you do? You will ask again rescan after 15 days or 2 weeks. Suppose if you get after 2 weeks also, again you can see that embryo is not there or heartbeat is not there, then you can label it as missed abortion. And same if gestational sac is with a yolk sac at any gestational sac diameter of less than 25 millimeter, and after 11 days you will again ask, and if it is if it remains the same, there is no embryo or heartbeat, then you can label it as missed abortion. So these are the 4 diagnostic criteria. It is always better if you have less than 7 millimeter CRL or less than 25 millimeter gestational sac, you advise better to go with ultrasound 2 weeks later again to reassess. And many a times as we have seen that usually 80% they get the things in their favor, and almost 20% will be labeled as missed abortion. Now coming to findings that are suggestive but not diagnostic and you have to wait. These are when CRL is less than 7 millimeter with no heartbeat, when the mean sac diameter is 16 to 24 millimeter without any embryo, when the absence of embryo for 6 weeks after last menstrual period. Suppose she comes to you and she says that her LMP is around 1.5 months back, and you scan her and there is no embryo. So you are suspicious that this pregnancy could result into an abnormal pregnancy. Then amnion is empty, yolk sac is more than 7 millimeters, so fetus is not there, developing embryo is not there to take its share of this, and so yolk sac is more than 7 millimeter. And as compared to the size of embryo when gestational sac is small. So these are the findings that are suggestive of abnormal intrauterine pregnancy, and you have to wait again, you have to scan her again after around 2 weeks to label it as missed abortion. And thank you very much to be with me in this video, and if you like this video, please like button, then subscribe and share among your friends to spread the knowledge. Thank you.